Okay.
We can start in the front and then kind of make our way back, or you want to start in the back?
Oh, yeah.
Yeah, go for it.
Okay, so the question I wrote down at the end of Dr. Miller's talk, you just pointed on, which is what are some sort of approaches or strategies for finding a good provider for that healthcare team? What are some questions that you would ask, specifically, finding a gynecologist that's well versed in menopause, because it seems like they're
So first of all, I mean, there was a study, it's a little old now, 5 years ago, that polled internal medicine, family medicine, GYN residents, and only 7% of them actually felt like they could care for people in the menopausal transition and beyond. It's not a requirement like knowing how to do surgery or knowing how to do these specific things. And so as a clinician who specializes in menopause, those are the people that you probably want to talk to. The way that you find those folks, menopause.org. So menopause.org, people like me who are either members of the North American Menopause Society, which is now the Menopause Society, it used to be called NAMS, it's not anymore, it's the Menopause Society, or so either members or actual certified specialists. So what does that mean? That means that in the couple of years leading up to getting specialized, I did courses, I went to different conferences to get like my continuing medical education, and then I took an examination. I passed that examination, and then every 3 years I have to submit to this society that I'm staying abreast of the latest and greatest in the community, and which requires me to also attend the meetings, which really covers not just hormone therapy, but it's covering obesity medicine, bone health, it's covering cancer health, it's covering sexual health, it's covering all of these other things. So that's how I stay up to date, because there really isn't a way to do it. We are in a place that's a little privileged because we have lots of menopause certified folks. I used to be at Emory for over a decade. And so there were several of us there, and have my own practice. And so I see patients in my practice. And if you go on menopause.org, in the state of Georgia, there are quite few number of folks who actually see people. If you're in other states, it's actually not that high. So if you look at gynecologists, for example, which is generally where people get their care when it comes to menopause, 20,000 plus of us in the country, 2,000. And this is like representing dietitians, public for physical therapists, physicians, nurse practitioners of all kind of different specialties are certified. So the numbers are not high. In Georgia, it's a little bit better. There are some online platforms that provide, like I'm associate medical director for Evernow, which is an online telehealth platform delivering perimenopausal care. And one of the requirements is that within the first year, the nurse practitioners, like I do the training for the nurse practitioners. And one of the requirements is that they get menopause certified in a year. And so it's part of like the education. How do you approach a patient with this? How do you choose hormone therapy? I do the trainings and the like, and develop all of the guidelines with the team. But there is that expectation that they will go on to be considered experts. So when I think about, I love what you said. It is really a team effort. And I also know that we're speaking with some privilege that like, get a team, nutritionists, things like that. I'm like, sign me up when we go in.
I know.
But it really is kind of in the same way. I have kids that I'm like, okay, we're doing school and talking to the teachers and getting a tutor and doing extra worksheets at home. It really is all hands on deck. It's the same thing for this transition. So I see my role as a menopause specialist working in conjunction with the gynecologist who may not have my expertise. I don't operate anymore, so I wouldn't do a hysterectomy right now. You don't want me doing a hysterectomy, right? Right. I would send to the specialist in the same way my expertise is menopausal health. So I empower patients to also seek out help from that specialist. And the other thing, I know my soapbox.
No.
For most people, your gynecologist is the one that went through it with you, whether it was contraception, trying to get pregnant, trying to avoid pregnancy, birthing children, all of these things. So for some of us, we feel so indebted to that person in that relationship because there were so many critical, crucial moments. And then when we get to this life stage, they just don't know. It's not that they're trying to be dismissive, maybe a little bit, but it's really because they just don't know. And we were taught this is normal. I'm telling you, be picky. Okay, so if that means thank you for my pap test, let me go on this menopause.org website
Yeah.
and find somebody to work with, then I want to empower you to do that. And even if you see that person as your consultant, that's how I think of myself. I think of myself as a consultant that can handle the menopausal things in the same way that if I send someone to an endocrinologist and they need diabetes management, they're going to get their diabetes managed by that expert.
And that's what I would say when you're in your session with someone, like, do they listen to you? Do they,
Mhm.
I mean, do they seem well versed? Do they seem like they're up to date with things? And if they're not, then you accept the help that they can, and then you just keep looking.
Yeah, if
So,
you have a
or you
doctor that's
get
still
wrong information.
yeah,
Like,
or if you still have doctors telling you like, no, it causes cancer, it's not safe. They have not read the literature.
yes.
They are not up to date. So
Or like they say, oh, you can be on it for 6 months. Why do you want to start it so soon? You're like, you're going to have to go off it.
Mhm.
Like run, not run,
Mhm.
but
Yeah.
okay, good to know. Thanks. Yeah.
And you bring up a good point, and I think the question hasn't been asked, but it's one of the big things that come up is about weight gain and understanding the interplay, some of what you've talked about, but also the rise of insulin resistance as estrogen levels decline. For many people, as they start going through the menopausal transition and they're first noticing some of the menstrual cycle changes as well as the vasomotor symptoms, they also may notice that even if their weight hasn't really budged on the scale, and we do know there is about a pound or so a year around this transition. So on average, it says 5 pounds, although a lot of my patients will argue that it's way more than that. But they also will notice the deposition around the midsection. So a couple things that happen with that. One, as you're going through the transition, especially if you're not getting good sleep, especially if you're having, like you said, that sandwich generation, and you don't have really good tools for managing stress, it increases cortisol. And cortisol is lovely. It doesn't know that you're not being chased by a bear. It's just trying to help you survive what's happening in your life. And so we start seeing increased fat storage, which preferentially will go into the belly section, but then also sweet cravings because carbohydrates are a very efficient source for foods for fat storage. And so we see that also you're seeing with age, but then also with the increased belly fat, that increased insulin resistance. We also know that estrogen levels decline. We see also a bump to insulin resistance. And so when we have that bump to insulin resistance, I hate to say it, we do have to modify our diets. The things that we can get away with when you're in your 20s or your 30s really start to shift, especially some of the simple carbohydrates, because they're going to preferentially be used towards fat storage because you have elevated insulin levels, cortisol levels, and you're more resistant to your body's insulin, which means that your body has to release more insulin. And what does insulin do? It regulates your blood sugar by fat storage. So we haven't really talked a lot about that. The role of hormone therapy for that, obviously dietary modification. You've probably seen a lot about how do we shift. I never say you need to diet. I say look at your plate and let there be a reallocation of where your calories are coming from. So in the American diet, very carbohydrate heavy. When you think about pasta, potatoes, things like that, I want you to again look at that plate. And if half of that plate are some of the more simple carbohydrates, so the breads, the potatoes, the pastas, even if you started out taking half of that and adding on more vegetables and lean proteins, whether that is taking something like lean chickens, tofu, other protein sources that are one going to be beneficial for you as we're talking about building up muscle and maintaining muscle.
Yes.
Because we haven't talked about anabolic resistance. As we get older, our body does not make muscle as efficiently, even though we know we need it. As we think about longevity, just make those little shifts. Not telling people like to kind of like to cut down completely on the calories that they're eating. You know, I think that that gets into a slippery slope with some disordered eating, but really a reallocation of where you are actually getting your calories from.
Yeah, because if you do calorie restriction as well, that's just going to set your body, it's just stressing your body out, right? And with the protein, well, back to, so we want to build muscle. Our body has a hard time building muscle. But when we do build muscle, and that's like, again, it takes weight training. You have to challenge the tissues for there to be a response. That is metabolically active tissue, right? So that's going to help with the blood glucose and insulin resistance. And really, there's more studies coming out how like just muscles are like nature's pharmacy. I'm not saying it's replacing estrogen, but you know, it helps our body in so many ways. besides, aesthetics and lifting. And, it's really that blood glucose and the insulin management as well. Recently, I've been learning more about, just the timing of when you eat your food. So the biggest thing is like, we should be getting 1 gram, I even hear 1 to 1.1 grams of protein per pound of body weight every day. That is hard to do. And so, and so what'd you say?
I said I usually recommend half
Oh,
because
yeah.
it's a lot.
It's a lot. And so what I kind of recommend is like, you really pretty much can't do it just by food. Like, you're going to have to find like as clean of a protein powder as you can. Collagen is not a complete protein, so you want that to only make up like 30% of your protein. I used to think collagen was more, so I'm like, darn it. But truly, when you wake up, the other thing is you don't want to wake up and like fast and like exercise before you've eaten. You really got to wake up. And I've heard even like you want to have at least 15 grams of protein within 30 minutes. Yeah, exactly. And so
this is what they say.
Right. And so this is where like maybe some liquid is easy. You just shake that up and go. You're not like actually making sausage or whatever. So I usually have my liquid protein in the morning, and then you want to either literally right before, during your workout, or right after. We're talking, and again, this is what we're finding as we age. Men have this 3-hour window. We have got like 45 minutes. If you don't get that protein back in your system dietarily, now you're actually be breaking down your muscle to build them up. It's actually, you're doing reverse. So you can be going to the gym and doing all the things, but if you're not fueling your body right, it's like, no go. And I remember when I was going through PT school, it was like only the gym rats worried about that. Like, we are the movement experts and we did all this, but we never coach people on the timing. And now we have so much more of an appreciation of this. It's like, you're not trying to look like Arnold Schwarzenegger or whoever, but you really need to get your protein in, because we just have a hard time synthesizing it and holding it. We need to, I really was mostly vegan from like a good majority of my middle years. And now I'm just like facing it that I have to have some more meat, some real animal-based protein. So again, you can absolutely do it vegan and do it, but it's a lot. It's a lot. You have to be on point.
Yeah, so there are a couple questions back there, then we'll come around and then we'll go back over that way.
Okay.
Okay, I have 1,000, but I'll have.
Okay.
Okay, can you please clarify for me, vaginal estrogen? May you use it while you're still having periods, even if you're transitioning? Because I'm like, do I put someone on a stronger birth control pill that has more estrogen in it to help? Do I not do that and they need estrogen cream, but they are still having sex and they could potentially conceive? Like, what do I do?
It depends. It all depends on what the goal is.
Okay.
So not getting pregnant, so we need some sort of contraception, and not having pain or dryness or something like that
Yes.
So we talked a little bit like about why would you prescribe a birth control pill for menopausal? So maybe I'll back up there, like perimenopause. Here's the thing, very honest with you. Birth control pills are very convenient. They come with estrogen and progesterone. They're very cheap. Your insurance, based on the Affordable Care Act, actually covers it. So if you're looking for something that's the most cost effective, absolutely something that you can use. And if there are bleeding issues, so say menstrual cycles have gotten heavier, or it actually is the best at controlling bleeding issues. Menopausal hormone therapy does a very, very lousy job at that. So if I have someone that's maybe experiencing heavier periods and we've done a workup and it's just kind of like this perimenopausal space, and they're like, that is a goal of mine, having vasomotor symptoms, also in need of contraception, a traditional birth control pill is actually quite effective. I usually would recommend, if they're having vasomotor symptoms, that they use it continuously. That means if you have a traditional pill pack, it has 3 weeks and it has that placebo week, chuck the placebo week and go into like another fresh pill pack so that you don't get that hormonal break. Some people want that. Some people may experience some breakthrough bleeding that can be managed. And then if I have someone who is, because for some people who use a traditional birth control pill, which many of them are low dose, they may actually experience vaginal dryness. There is nothing wrong by adding vaginal estrogen to that. So we really, that's what,
Low dose.
on any.
On any.
On any. Yeah, on
Okay,
any. So I'll have some folks that are like typically we'll do like a 20 microgram ethanol estradiol. Now I'm getting in the weeds.
I
Pill.
have it written down.
And it's
Yeah.
low and it's low. Sometimes we'll do 30, sometimes we'll do 35. It really depends on how the patient's responding to it in terms of the goals. Is it controlling the bleeding? Is it controlling the vasomotor symptoms, etc.? If there is vaginal dryness, there is nothing wrong by also adding on the vaginal estrogen in addition to what you're doing systemically, because they're actually treating two different things. And so it's really understanding what are the goals here. Now, what I will say is the CDC has a wonderful US medical eligibility criteria. Here's the tricky thing. As we get older, we start accumulating diagnoses, right? So as we get older, we might start becoming hypertensive. We might develop a history of blood clots, all of these things that would actually be a contraindication for a traditional birth control. So really having a good history is really important. But for someone who's otherwise healthy, believe it or not, the recommendation is that you can continue them on a traditional birth control option, whether that's a ring, patch. Technically, I'm not a big fan of the patch or the pills up until age 55.
With, I'll now, any withdrawal bleeds at all in that year,
You don't need to.
really?
What will happen is that they may experience some breakthrough bleeding.
Right.
If they experience breakthrough bleeding, then I usually will recommend a 4-day pill break. Because if you do the full 7 days, lots of symptoms are going to come back. It's like, and 4-day is like the sweet spot before you actually like start losing effectiveness for contraception and things like that. So I like to give it 4 days so that they can shed and then restart it and minimize kind of any of those breakthrough vasomotor symptoms or things like that.
Great. Second question, I know everyone wants to share. How do you feel about when people come in and they're 38? I want my perimenopausal lab. I get so like, it's really not worth it because one.
Yeah. It's really tricky because if you Google right now, very well-known medical influencers are telling people that they need their labs.
Right.
The big thing that I say is, what is the question that you're looking to answer? Because sometimes we think that the labs are going to tell us whether or not we're in perimenopause. And I say there's a lot of other ways that we can get to that. I'm old, I got gray hair. I don't argue anymore. I try to like understand and I try to say, listen, it's going to, you're having regular menstrual cycles, your menstrual cycle cadence hasn't changed. It will be normal. And when it's normal, I still will treat you if you're having symptoms. If you're having hot flashes, if you're experiencing that first sleep disruption, if your mood is starting to change and you know what your mood baseline is, we can test you. You're gonna get a bill in the mail. And it still won't stop me from treating you because that's what happens. People get the labs, they're normal. And normal I say in quotes because it varies throughout the cycle. And then they're like, it's normal. And they get a message on their portal and it's normal. And the conversation is over. So I like to start, what are we looking to answer? What do we think these labs would tell us? We live in an information age. People want like something concrete. And it's because we have not been taught as women to trust our bodies and to trust what's happening in our bodies. We need to see the data because the data matters more. So I will tell you 9 times out of 10, the people who get the labs and they're normal, they still don't feel better. And I tell my patients this, I'm like, what are we trying to answer here? I think that's the real question. And then if we go on and on, I'm like, okay, girl, let's go ahead and order these labs. And
Like I did today where I was
yeah, but it's tough. It's tough. We're gonna circle around. Yeah.
So maybe this is a very basic question because I'm not a doctor, but so for those of us who have IUDs and we don't have periods, how do you diagnose menopause and how do you know when you're not fertile and you can rip that baby out and start doing other things?
Yeah.
This is a great question.
I have this question too. Because I'm like,
So
no.
funny story. I actually did a review article on this with like some colleagues. And this was the question I had. I was like, tell me more. Like, what do you do? It comes down to questions. Do you want to get rid of your IUD? We know that by age 55, 90% of people will be menopausal. If you are 50, 51, 52, my question, and you're like, when can I get this thing out? If you really want it out, we could pull it and then see what happens with your cycle. If you have that as an option. For some patients, they don't really have that as an option. They need some sort of reliable contraception. And in that case, I generally would recommend for contraception, the Mirena IUD, for example, or the Liletta, the 52 milligram, I shouldn't use brands, the 52 milligram levonorgestrel IUD, you can actually go ahead and use it for contraception to age 55 and pretty reliably will have gone through menopause. Okay, so that's the first thing.
But you don't really know.
Right.
You don't really know until it's out. Some people say, well, can you test my hormones? Sure. What are we trying to answer? If we can take out the IUD, okay, we could test it.
But if it's a hormonal IUD, will it,
It does not impact the actual hormonal test that we would do.
and does it, are those the same hormones that we're talking about deficiency for perimenopausal or menopausal symptoms?
Yeah, so there's
it's replacing them?
No, so the IUD is really localized to the uterus and it's a progesterone IUD. It doesn't work in the same way as like a traditional birth control pill. A traditional birth control pill is giving back just enough estrogen and just enough progesterone to kind of screw up the whole pituitary, pituitary, ovarian, hypothalamic, I went backwards, axis,
Yeah.
right? The IUD is really central. So the IUD, most people are still ovulating. Actually, the vast majority of people are still ovulating with the IUD, especially as it gets later and later, because it's really localized to the uterus. It works for contraception in a lot of different ways, but primarily it thins out the lining of the uterus, which is why you don't get periods. And it creates a big old mucus plug, which kind of like makes the sperm go like this when it kind of gets there. Like literally under the microscope, they're like this. And so for
They break apart.
there's a big mucus plug. Think like pregnancy, mucus plug. The progesterone in pregnancy, that's what makes the mucus plug. So when sperm goes into reproductive tract, they get stuck in the mucus plug. They get stuck in the mucus plug. So if I have someone that's starting to experience, say they have an IUD and it's less than 5 years, 5 years is important, and I'll come back to that. If they have one of the higher dose IUDs, so the levonorgestrel 52 milligram, within 5 years, and they're in their 40s and they're having symptoms of menopause, like hot flushes and night sweats, I treat them. In fact, the IUD, the higher dose ones, can be part of your hormonal treatment. We have studies that only go out to year 5, that if I'm giving you estrogen as form of replacement, that I can actually use the IUD as your progesterone. Anytime you have a uterus, you have to have both. After 5 years, we don't have the data, so we usually recommend getting a new one. Age 55, I have some people that pull it out, they put a fresh one in, they keep going with their hormone therapy, they're happy as can be. But insurance stops covering it for that reason at age 55, because it's technically FDA indicated for contraception and for heavy menstrual bleeding and not for management of hormone therapy. But we try to get it in there before age 55. I do at least. Yeah. So I have some like people like, I'm having symptoms. Let's just assume you're in perimenopause. If you're not having symptoms, you don't know, I'm happy to do what's called a follicle stimulating hormone. Follicle stimulating hormone is released by the pituitary gland. It communicates with the ovary, like, give me a follicle stimulate, give me a follicle. Ovary's like, okay. And so starts producing follicles, which then releases estrogen, feeds back to the pituitary, the FSH levels drop. As your follicle count goes down in perimenopause and menopause, FSH is sending lots of signals to the ovary, so those levels go up. And we generally use a level of 40 to indicate that you might be in menopause. So there is a way to check, but it all comes down to, back to your question, why do we want to know?
So if you're having symptoms.
Yeah.
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 Go with this.
Well, we'll treat the symptoms. You don't have to deal with it.
Right, yeah, that way.
So I have a question about HRT. So this is a whole body transition. But somewhere along the way, I've gotten the impression that HRT doesn't address the full range of symptoms that women might be having, which it's better.
Give me an example.
So could you expect HRT to address mood or skin changes, hair loss, joint pain, brain fog?
Yes.
Yeah.
Yes. So it's the decline in the estrogen that's causing that symptomatology. So giving you back a little bit of estrogen will generally help. You are right. The more common symptoms like hot flashes, night sweats, we know those are the most studied. So we know that they're quite effective. And in fact, hormone therapy is FDA approved really only for vasomotor symptoms. But do I have patients that they're like, I have the occasional night sweat, and it's really this brain fog. It's really my joints. Oh my gosh, I'm in pain. I will use hormone therapy and see if it works. And I find that it does improve because we're going to get improved joint lubrication. We're going to get a little bit more of a bump to the serotonin because I'm giving back a little bit of estrogen. I do outline to, it's all about expectation setting because if mood is the predominant symptom, especially in a patient who has already had a history of postpartum issues or generalized anxiety disorder or major depressive disorder, estrogen may not completely fix it. And so it might be a combination of adjustment of medication, but also estrogen, primarily. And we're talking a lot about estrogen, but and I'm surprised nobody brought up testosterone, but
Yes.
yeah.
Since you're not routinely checking labs, like what is your threshold of suspicion when you're sussing out people's symptoms for, do I need to get a testosterone?
Wow.
Yeah.
So I will tell you right now what the Menopause Society and like there's like it's called ISWITCH. I can't remember. It's like a lot of letters in their name.
Sexual health.
Section
Yeah.
the sexual wellness. The indication for using testosterone specifically is in the condition of what would used to be called hyposexual desire disorder. DSM-5 now calls it female sexual interest and arousal disorder, and specifically using it for that purpose. So what does that mean? That means that I think the consensus is replace estrogen, right? If there are issues in specifically as it relates to libido, replace estrogen. Do a medication audit. So some of the medications that you talked about, calcium channel blockers, SSRIs, they're so wonderful and they will knock your libido out. So SSRI, really doing a medication audit where you're seeing, okay, could medications be impacting interest? There are other medications on the market. They go by the brand names Adding and Vyleesi, so fulvestrant and bremelanotide, that specifically address sexual response because it's very much starts here in the brain. Now, with all of that being said, there is a place for testosterone. Libido is very complex. It's usually interest, which is really where testosterone plays a really big role. When we look at what happens in a normal menstrual cycle, you get a spike of testosterone around ovulation. This is the species way of trying to keep going. You get this big burst, and it's responsible for your drive, the sex-seeking behavior. So interest, arousal, kind of what we talked about, the physical response. So are we getting engorgement? Are we getting kind of that pleasure feeling when you're getting that stimulus? Orgasm ability, and then some pain issues. That's when we think about libido. So if I have someone that we've kind of run the gamut, we do have a conversation about testosterone. Couple of kind of disclaimers. We do not have an FDA approved testosterone in the United States. So anything that we're using is either compounded or we're using male formulations at a fraction of the dose. You do require laboratory testing to make sure that you're staying within like a goal, because if you go too high, that's when you get things like clitoromegaly, which is the growth of the clitoris, deepening of the voice, unwanted hair. Not a lot of data whether or not in the short term, you're getting some cardiovascular issues like increased LDL. We know that testosterone increases like your bad cholesterol LDL, but it hasn't really been studied very widely. So we know that we keep it within this confines. What gets tricky about testosterone is that lots of people are using it for lots of different things. So for muscle retention, we get a lot of people who are talking, I mean, medical influencers that are saying you should use testosterone. It's not just for libido, but you should use it to help maintain your muscle mass. We don't really have a lot of data. I mean, we don't really have a lot of data on any of this stuff, but we really don't have a lot of data. And there are other ways that we can get muscle growth. Same thing for mood. Using testosterone for mood. Testosterone makes you feel real good. It's that middle of the cycle, y'all feeling good.
Yeah.
Testosterone makes you feel real good, but there may be some other ways that you can do that may be safer. So the only time that I ever test testosterone is I try to stay in accordance with like the Menopause Society, liberal take on it, but that's generally when I will ask for testosterone. Now, what's interesting, you can't just test testosterone. Testosterone is only as good as what it's bound to. So it's more labs. It's free testosterone, total testosterone, sex binding globulin, and we put it in a calculator, all these things like that. So if somebody's like, let's just test your testosterone, they're not doing it right. Because if you have low sex binding globulin, which usually happens actually with perimenopause, as estrogen levels decline, that protein declines. For some people, their libido goes up because effectively less protein is binding to testosterone. So now your testosterone levels are effectively high in ratio. But yeah. Oh, it's so interesting.
I know, right?
I was gonna similarly, like, so I provide HRT for people who are seeking like gender affirming care. So I think for me that has like kind of demystified hormone care in a way that I didn't expect when caring for menopausal people, which has been kind of fun because you don't really learn about how to do menopause in school.
Right.
But it also makes me like, why don't we just give people a little testosterone? So I was kind of wondering, like, you know, I haven't done that because I practice that loose, but it seems, and in talking to my colleagues about this, especially I think for people who are suffering perimenopausally and people who are like suffering PMDD, seems like a little every other week dose of tea could be really helpful.
Yeah.
So I'm wondering, like, here kind of
I know.
do you know people who are doing that? Obviously,
Specifically for trans men?
or folks, yeah.
Like
No, I mean for cis women who are perimenopause.
Yeah, there are lots of people that offer a testosterone, not specifically for mood, and here's why. There are safer options. So some of the methods of of administering testosterone, orally, injections, pellets, or topical, the first three, you get a big overshoot in women so that you get lots more side effects, I should say. So that's when you're getting, maybe if you get too high of testosterone, there's an aromatization to estrogen. If you don't have the appropriate progesterone to protect the lining, now we're getting irregular bleeding. So there are other ways that can improve mood or PMDD that don't necessarily carry some of those side effects. I have not used that personally in my practice. I really use it exclusively for libido because I found a lot of success, especially for mood, with giving back estrogen, which is going to be a little bit better in terms of all health. When we look at cardiovascular health, brain health, bone health, you're going to just get more bang for your buck with estrogen. So I usually start there, but that might be my bias.
Clarifying question, could be the brain fog, but did I hear that you said that a patch, you were not a fan of the patch?
Oh, I love the patch.
Okay, so I'm glad I asked.
Good clarification. No, thank you. I'm not a big fan of the contraceptive patch. Goes by the name Zulane or Arthur Evra. No. The contraceptive patch. The reason why is that you probably get a little bit more systemic absorption of hormone than you actually need. And we know with even as a transdermal option and the contraceptive ring, ethinyl estradiol is a synthetic estrogen. And so while it's really good for bleeding control and contraception and all of those things, unlike menopausal hormone therapy, there is a bigger clotting risk. And so I have a lot of patients that you probably get more absorption than you probably need. So 60% more absorption with a contraceptive patch. Really not a big deal for the vast majority of people, but I've encountered patients that have had leg cramping, blood pressure changes, things like that, which is why I'm not a fan.
Transdermal patch?
I love the transdermal patch.
Bioidentical.
It is a bioidentical acting. Yeah, that's menopausal hormone therapy. So there's lots of different types of menopausal hormone therapies. We can give you estrogens as pills, as patches, as gels, as mist, as rings. I mean, there's just a whole gamut. I like the patch, my bias, because I have a mentor, he loves the pill. But I like the patch because it's transdermal, so it's going to lower the risk of blood clot. You can have it as a weekly or twice weekly dosing. So when I think of user friendliness, it tends to be friendly in that regard. And it comes in a lot of different dosages. So I can titrate to treat symptoms. The downside of the patch is skin site irritation. Some patches are created better than others. You might get a little bit of an adhesive issue. So I have some folks that are really sweaty and they work out a lot, and sometimes the patch falls off and we have to reinforce it with, waterproof bandages and things like that. And for some people, it can be a little bit more expensive versus an oral estradiol patch, which is also bioidentical. You take it daily and it's very cheap. Even if you had no insurance, like you would be able to likely afford it because it's usually about like $5 to $10 a month. So very cheaper than a cell phone bill, where you can take it. And the downside though is because it is an oral pill, it does come with some of the risk of increased blood clot risk. Theoretical, but as we age, our risk of blood clot just by age alone goes up. So we have to think about that and see who's at risk for that. And the patch just takes that out of the equation. But for folks who have really busy active lifestyles, they understand that risk. I'm happy to prescribe an oral pill. And there is some data that, like, if your symptoms are very strong mood symptoms, that maybe trying an oral pill helps a little bit more with mood symptoms just because of the way that it's metabolized by the liver.
By bioidentical.
Oh, good question. So bioidentical is just a term referring to the chemical structure of what a hormone looks like. So your body, your ovary, makes 17 beta estradiol. It is just the chemical structure of the type of estrogen that your body makes. There are now products on the market, vaginal estrogens, patches, and pills that are 17 beta estradiol as well. So they are chemically similar to what your body made. That's all that means. It's still made in a lab, but it's chemically similar. And the reason why folks like that is because when we think of potency, it's similar to what your body made. When we think of the types of receptors that it acts on, 17 beta estradiol may act on receptors that are less inflammatory than some of our synthetic ones, like conjugated estrogens, things like Premarin and things like that. So,
Yeah. Oh yeah.
Feel about like periods are wonky, there's not a whole lot of other symptoms, so you're not fully through the process yet. And starting HRT as like a way to
prevent it.
Yeah.
Yeah, I get this question a lot. And I generally tell people if your periods are wonky, you've started.
Yeah.
Right.
So even if you're not in a place where you're having hot flushes or night sweats or things like that, you have started. And so then we talk about what the goal is. Is the goal control of the bleeding? Let's talk about that. I have some people that are totally game. Yes, this bleeding is annoying. I don't have any other symptoms. We'll try a traditional birth control pill just because it's cheap, available, acceptable. If I have someone they're like, nope, I don't want a traditional birth control pill, but I do want something. There are some progestins, so not bioidentical progesterone, because that is pretty lousy to control bleeding, believe it or not. But there are some things that we can maybe give a little bit of systemic estrogen in like a patch or a pill, but then also give a progestin that's going to meet the goals of controlling the bleeding a little bit more.
What if you're thinking about it in terms of like, I want to avoid like bone loss and
Yeah,
or like all those things
as kind of preventive. So I generally have the conversation that no medication is without a risk. And so while we may be taking a medication for one thing, is it going to be causing something else? And that something else could be cost, time, because if you miss patches or you miss pills, now we're getting irregular bleeding, we're getting all of these things. And so it's a conversation. I do not have any problems with anybody who's in a perimenopausal transition who says, I want to take this for bone health or something like that. And we know within that first 10 years of their transition, you're going to get the biggest bang for your buck. The same mentor who likes oral estradiol, if you are somebody who's at increased risk, for example, for osteoporosis, at age 60, he takes everybody off of oral estrogen. And if you are at increased risk for osteoporosis, he will put you on the lowest dose patch, even if you're not having symptoms. And the reason for that is that it is FDA approved for the prevention of osteoporosis, but then also if you broke your hip, that's a whole different conversation.
Yeah.
So if you have a family history, personal history of fractures or anything like that, or are currently osteopenic, that is his strategy. So it's not unusual to use it in those situations. And it is actually FDA approved for prevention of osteoporosis.
Okay.
It's not going to cure the osteoporosis.
Yeah. One more. Yeah.
Okay, so I'm 44, I've had 4 children, the last one was
9.5 pounds. So I have pelvic floor issues,
Mhm.
obviously. My question for both of you guys is, you talk about this team, how does somebody with limited funding
Mhm.
have a team? Because, you know, go to the midwife after this 9.5 baby and say, I'm feeling heavy down there, and she's like, I can't find anything wrong.
Mhm.
And then you look into pelvic therapy, you know, there's nobody that has
Mhm.
insurance.
Mhm.
So now you're coming out of pocket thousands of dollars that you don't pee and sneeze at the same time. On top of the fact that, you know, like the hormone therapy sounds great, and I think that that is within the realm of insurance, but I have a whole other issues that also
Mhm.
compound it. How do you, as a woman,
Yeah,
Yeah.
I'm
navigate that? Like,
Oh.
it's insane.
totally.
Yes.
I absolutely hear you. And I think a lot of times we come into thinking about physical therapy, like orthopedic physical therapy. Like patients are like, oh my gosh, I have to come in 2 times a week for 4 to 6 weeks. Like, no, you literally have one visit. So you have your assessment. Just having that assessment can give you so much knowledge. So in the first visit, it's not just assessment, right? So we assess and you get a home program. And I have a lot of patients who just say, okay, that's what I can do for now. Like, and we just beef up their home program and say, okay, this is what you're doing, and run with it. They may check in a month, they may check in 3 months. So really, it's not like traditional ortho PT where you have to go and do all the things. No, like, we're going to teach you what you need to know that you can run with it, do what you can at home if you want to check in or progress your home program. But I promise you, just even in that first session, learning how to breathe properly, learning what's going on so you're not doing the opposite things that are counterproductive. Like, I really treat a lot of people, we just see them one time and then, you know, and sometimes they don't come back and I'm like, oh, then they leave a review for me and they do something. Well, oh, one visit, it was great. I'm thinking, you know, I didn't know how they went, but they literally stopped the bleeding, stopped the this. So like, I didn't
Yep.
need you anymore. Like, you were great. Like,
And I
so
would, yeah, and I would say
that's
most people are
possible.
pretty motivated, right? Like leaking, can't go in the trampoline with the kids. Like it's not
Yeah.
fun.
And I mean, like almost 4 years ago,
Right.
you hit home of like, this is not gonna get better.
Right.
And as I've got older, I've got joint pain and all the other signs and symptoms, the shortening of the periods, they're coming at 25 days instead of 30, you know.
Mhm.
I mean, you're at the
So I'm like,
prime
oh,
age. But
okay.
do you feel like your patients are pretty motivated? Like I would
Absolutely.
say like one visit,
I really,
plan,
and
you're
I mean, at the price,
you're
I
doing all the
understand. That's why,
things, you know?
but I have an article on our website, renewpelvichealth.com, that says, you know, why the benefits of seeing an out of network PT. And I hear this all the time because I have patients that will come to see me for pelvic health and they go see their ortho PT for, you know, their knee or something else. And it's just like the quality of care that you get from an
Yeah.
out of network, like,
For them. I mean, like,
yeah,
yeah,
yeah.
just trying to find something is like, nobody knows
Yeah. Yeah.
where I'm supposed to go. It's
And then you get some
crazy.
your GI doctors,
Take care.
for therapy and you go, and all they do is tell you to do people.
Yeah.
Like, yeah, that's not what I'm supposed to be doing.
Yeah.
I don't-
I mean, a lot of it's quality, right? It's time. It's like, what are they gonna like? I mean, I'm not to say that the people doing that they're not passionate, but I've
Right.
been in a care model where I was seeing 25 patients a day.
Yeah.
And there's not a lot left over for the patient when you have 5 minutes spent on check-in, 5 minutes spent in a visit, and then 5 minutes where you are like trying to wrap up.
Mm.
And so it's not really serving anyone, unfortunately, in our service model. So I think when you do come for the one appointment, especially our patients are really motivated, you'll get that plan. And like I said, you'll be sitting in front of the TV, you know,
Well,
doing
and you
that
see, like, I mean, the way that we run this practice, the practice here is because I spent so many years, like, God, 13 in insurance-based model. So it's like I show up to the visit and I have no idea what's going on with you, right? So I mean, you're filling out your paperwork when you arrive, and if you arrive at the time, then that's eating into our time. They're stressing me to like, don't even have an hour with your patient, do your sessions. They always want more productivity, right? We're here, you know, you get all your paperwork when you make the appointment. So you have time to fill it out. I have time to research and say, oh, I don't know that medication that they're on. Let me see about that. Let me do my work and prepare before you even come in. So when you come in, we're asking clarifying questions and we're getting to the assessment part. We're getting to the treatment part. we take as much as we need with the subjective like talking part, but I review that before, Ariel reviews that before, so that way we are the most efficient with our time in the clinic together. And then even with follow-up visits, we're not doing here what you can do at home. Like I'm not just going to count reps for you doing exercises, right? So we're progressing your exercises, we're getting some more education or learning in your body, feeling what's going on, progressing your home program, and then lots of hands-on. Manual therapy is our passion. So things that you can't do at home. So that's why I said, like, you really, I can speak for our practice, like you're going to get so much value out of the time. And because we're not seeing 10, 12 patients a day, I've got the bandwidth. My body is in a state to help your body, right? So when you're in the insurance-based model, especially if they don't do, that's one thing I'd say, if you go with an insurance-based model, make sure that they do pelvic health, period.
Yes.
Because if they're doing ortho and pelvic, they've got people in the gym, so they're mentally maybe with you, but not really with you, because they're worrying about, oh gosh, they're doing that poor form, I got to go over and correct that. But they're having their time with you. So it's really, the one-on-one is so important. Yeah. Thank you for all your time. Yeah.